So what we did in ADAPT ES was to try to overcome many of the limitations of most registries, which have been relatively small and have had 4 to 6 events, which were leading to the conclusions that DAPT hyporesponse platelet function testing showing hyporesponsiveness to DAPT was associated with subsequent events. And what we did was we planned on enrolling up to 11,000 patients at 11 sites in the United States and Germany, trying to take basically all comers with very few exclusion criteria, essentially no exclusion criteria, who had PCI with at least one non-investigational drug-eluting stent placed, which was successful and uncomplicated. After adequate loading with aspirin, clopidogrel, and washout of glycoprotein 2B3A inhibitors, in case there were any such on, we assessed platelet function testing with the Verify Now test, and we assessed aspirin responsiveness with the Verify Now aspirin test. We tested clopidogrel responsiveness with the PRU test, both the base level, the percent inhibition, and the absolute PRU inhibition. And we tested overall platelet function with the glycoprotein 2B3A test that measures in PAU. We're following patients for up to 2 years in this registry, and what we're going to present today is for the first time is the 30-day data. So there are basically 6 or 7 different measures that we could get, and this slide shows in a total of 8,653 patients that were enrolled in this registry, the relationship between definite and probable stent thrombosis within 30 days versus no definite probable stent thrombosis, and the rate of stent thrombosis was 4.46% or 39 episodes. And you can see on this simple univariable analysis there was no relationship between stent thrombosis and aspirin hyporesponsiveness. As measured by the pre-specified cutoff of greater than or equal to 550, only approximately 5.5% of patients actually had aspirin hyporesponsiveness, and there was no relationship either as a continuous measure or as that cutoff. There was also no relationship between the base P2Y12 level and subsequent stent thrombosis, although there was a very strong relationship between the absolute level of PRU and the percent inhibition of clopidogrel of platelet function as assessed by Verify Now. You can see in this univariable analysis, in particular, inhibition of greater than 11% was very strongly related to subsequent stent thrombosis. And these are all pre-specified cutoffs of the aspirin of ARU, the PRU of both 208 and 230, and the inhibition, all the continuous variables were pre-specified to be looked at in quintiles. This is the lowest quintile. There was no relationship, however, between overall platelet function response and stent thrombosis. Now, we then put all of these variables independently into a multivariable Cox proportional hazard regression to see adjusting with a propensity score analysis of all the different factors that were associated with platelet function abnormality, whether or not they independently predicted subsequent stent thrombosis. And so this is a model that adjusted for diabetes, no diabetes, acute coronary syndromes or not, and stent length. And you can see here, now these are individually values that are entered, you can see that there were 3 variables, the same ones that I showed you on the last slide, that were associated significantly with subsequent stent thrombosis, and fairly strongly so. And that was a PRU of greater than 208 or greater than or equal to 230, which were our pre-specified cutoffs, as well as an inhibition of less than or equal to 11%. And these all had a hazard ratio of about 3. If you use a multivariable model, you can figure the number of attributable events and the attributable percentage of events of stent thrombosis, and you can see somewhere between 30 to 50% of events in this equation were, quote, attributable to these this abnormal platelet function response to clopidogrel. On the other hand, if you look at the other 3, that is aspirin, the base level of ADP antagonism, and the overall platelet function response, the GP2B3A test, you can see there's absolutely no response whatsoever, no relationship to subsequent stent thrombosis, no significant attributable events. Now, that was the good news. What makes this more complicated, though, is that when you look at these tests, there's actually relatively modest sensitivity and specificity to be able to predict and find either the abnormal events or the normal events. So you can see, looking at the 3 that were actually predictive, we've got sensitivities and specificities in about the 50 to 70% range. And that becomes important here because when you look at the box plots or the overlap to try to get an estimate of whether or not this would be useful in the individual patient, you see something that looks like this. This, for example, is the Verify Now P2Y12 PRU test, and here's patients without stent thrombosis. That was 8,402 patients. And you can see here the median PRU is certainly lower than the patients who had stent thrombosis, 188 versus 252, p-value of 0.0001. But there's a huge wide overlap here. And in fact, if we had put this as dots, there's 8,402 dots here, and there's 39 dots here. So if you, this would just be a solid mass of dots on the left. So if you were actually to look at any single dot and a patient, there is so much overlap that you can't tell with any sort of reliability whether that patient would fall into the stent thrombosis likely category or the no stent thrombosis likely category, and that's what it means to have only modest sensitivity and specificity. Now, we looked separately at multiple subgroups. I can tell you whatever relationships we found were consistent in diabetics and non-diabetics, but for time I'm going to show you the more interesting ACS and non-ACS subgroups, and then we'll conclude. With acute coronary syndromes, which was approximately half of the population, 30 of the 39 stent thromboses occurred in patients with ACS. So you're talking about rates of around 0.7% versus about 0.2%. So stent thrombosis, very infrequent in patients without acute coronary syndromes. And in patients with acute coronary syndromes, these three events seemed, again, quite strongly correlated with stent thrombosis, strong p-values, high attributable percents. On the other hand, in patients without ACS, you can see, again, only 9 events without ACS, and the adjusted hazard ratios and the percent attributable events, of course, are not negative because there's so few events, but you can also see that the percent attributable events also tend to be less. So it doesn't seem even as predictive in patients without acute coronary syndromes. So we conclude that the absolute and relative levels of platelet inhibition to ADP antagonists as assessed by Verify Now P2Y12 test are powerful independent predictors of stent thrombosis within 30 days, with a significant proportion of events independently attributable to clopidogrel hyporesponsiveness. In contrast, the base level of platelet P2Y12 response, as well as aspirin and overall platelet responsiveness after DAPT loading as assessed by Verify Now, were not shown to be related to 30-day stent thrombosis. These data suggest that agents which more effectively inhibit ADP-induced platelet activation should reduce 30-day stent thrombosis when applied to large patient populations, and this underlines the positive findings of both Triton-TIMI 38 and Plato. Conversely, the modest sensitivity and specificity of platelet function testing, coupled with the low prevalence of stent thrombosis, implies that testing of platelet ADP antagonist responsiveness is unlikely to provide useful information to guide clinical decision-making in most individual patients for the prevention of stent thrombosis at 30 days. So good on the population level, but not so helpful for individual patients. The degree of platelet responsiveness to ADP antagonist loading is useful to predict 30-day stent thrombosis in diabetic and non-diabetic patients, as well as those with ACS, but may have less clinical utility in patients with stable CAD. The very low stent thrombosis rate in patients with stable CAD, coupled with the poor prognostic utility of platelet function testing in this setting, suggests that assessing DAPT response in patients without ACS undergoing PCI is unlikely to provide incremental clinical utility and likely explains the negative results of trials such as Gravitas and Trigger PCI. And finally, these data apply only to 30-day stent thrombosis and only to Verify Now. The relationship between platelet responsiveness testing and the occurrence of late and very late stent thrombosis in both patients who have maintained and discontinued DAPT will be assessed during the 2-year clinical follow-up phase of the ADAPT-DES study. Thank you.